Thank you very much and good morning. If I'd be a surgeon sitting in the room, I would probably be wondering, why should I pay attention to immunotherapy? It's something really not related to what we do in the operating room. The short answer is very likely that this will have an impact in your practice in the next years, and I will try to explain you why. These are my disclosures, some of the agents I will be discussing today. So these are the hallmarks of cancer. Hallmarks means these are the capacities that different cancer cells share in common and make them malignant. And also, for these reasons, the targets of the systemic treatments that we have developed in the last years. But interestingly enough, basically all the systemic agents that we now use are based on the attack to two of these hallmarks, which is the sustained proliferative signaling and the angiogenesis. So we basically have anti-proliferative drugs and anti-angiogenics to treat cancer. And we, for the last 2 decades, have paid little attention or have had little success in developing drugs against these other hallmarks. This has changed with including the ability of the tumor cells to avoid immune destruction. And now immunotherapy is a very hot topic, not only for the treatment of liver cancer, but the treatment of cancer in general. I'll show you the reasons why. First, I would like to remind you that the immune response and the immune response against cancer too is a very complex mechanism. The tumors have to have antigens, so proteins that are different from self-proteins. They have to be expressed in the proper way so that the system is able to recognize them. Otherwise, the tumors will be ignored by the immune system. Then, if the antigens are recognized, the cells recognizing the antigens have to travel to the lymph nodes. They have to get engaged with the T cells, which are the effector cells, the cells that kills tumor cells. And then upon activation and expansion, these T cells have to again reach the tumor site, and they're get in contact with the tumor cells and kill them. And one of the main problems in cancer, apart from some tumors being silent and becoming ignorant, is that this tumor niche, this tumor microenvironment is full of cells, of immune cells that are either not active or are not doing their role in a very proper way. And this is so, we now know quite well that the immune cells that are infiltrating the tumor, if they are doing so, have a very exhaustive and immunosuppressive phenotype. They show a series of exhaustion markers. Exhaustion means these cells are there, but they are not able to induce tumor cell killing. There is also a clonal accumulation of immunosuppressive cells that includes what we call regulatory T cells. They are T cells, but they play a negative role in the immune response. And tumor-associated macrophages. Again, immune cells that are playing an immunosuppressive role. And in the environment, there is a low expression of inflammatory cytokines that are needed for an effective tumor cell killing. Is this important? It is. We've known for some years that when we analyzed the tumors of patients that had been resected, the more infiltrating immune cells, the longer the time to progression, and the lower the number of these immunosuppressive regulatory T cells, the longer the time to progression. So the immune status of the tumor at the time of surgery is an important thing that defines the prognosis. And so, manipulating the immune reaction is likely a good way to improve the outcomes, not only in other situations, but also in the situations of patients that could be resected. The advances have come from the use of what we call checkpoint inhibitors. And to know what these checkpoint inhibitors are, we need to know what checkpoints are. Checkpoints are molecules that are expressed in the surface of the immune cells and provide the fine-tuning of the immune reaction. Here you have an active T cell expressing some of these checkpoints. In this case is the PD-1 receptor. And the PD-1 receptor is there so that when the active cell, the T cell becomes active, it's able to act against antigens, then it expresses these checkpoints in the surface, PD-1, so that the immune cells can interact with them and provide a negative signal and turn the T cell inactive. It's a natural break for the immune system to prevent an overreaction. Otherwise, we will be overwhelmed with inflammatory reactions with every infection. Tumor-wise, the problem is that in the tumor microenvironment, the tumor cells and other cells present in the tumor microenvironment, not necessarily the tumor cells only, express the ligands for these checkpoints and are therefore able to inactivate the T cells that have made their way and reached the tumor microenvironment and make them ineffective. The thing is now that we have monoclonal antibodies that are able to engage to the checkpoints and avoid this interaction with the ligands and therefore avoid the way these ligands make the T cells inactive. So they're able to release the brakes to the immune system and restore the activation of the T cells. PD-1 is one such checkpoint, but there are many others. On the right hand of the slide, you see a number of acronyms for molecules that, similar to PD-1, are able to provide negative signals. And agents targeting these inhibitors will therefore be ready to stimulate the immune response. And most of the clinical development has been produced with drugs that interact with PD-1 or PD-L1, nivolumab, pembrolizumab, durvalumab, atezolizumab, and also CTLA-4, which is also an important checkpoint. And the drugs targeting these checkpoints have now been approved for their use as first or second-line therapy for a variety of tumors, including hepatocellular carcinoma, showing that indeed the mechanism of action is valid irrespective of the tumor that you're treating, to some extent. The experience on the use of immunotherapy using checkpoint inhibitors in liver cancer started a few years ago when we had the opportunity to treat a few number of patients with hepatitis C-related hepatocellular carcinoma and showed, and this was later confirmed by other studies from the NCI, that this drug, tremelimumab, was able to produce objective remissions in 4 to 5 patients. And these responses were durable, and the time to progression that is usually in this situation 1 to 2 months was prolonged to around 6 to 7 months. That was a signal coming from small-sized studies. But then PD-1 jumped into the scene, and 2 large trials were designed, including hundreds of patients that you can see here include patients with all etiologies, hepatitis C, hepatitis B, uninfected patients, all of them with preserved liver function, of course, but most of them with very advanced tumors that had gone through surgery or local regional therapy, most of them through sorafenib, and had either metastases or vascular invasion, so very advanced tumors. In these very advanced tumors, the first thing that we were able to show is that the treatment was, as it is in other tumor types, in cirrhotics too, very well tolerated. These are grade 3 and 4 severe adverse events related, and they are very rare, both with pembrolizumab and with nivolumab. Basically, the most common are lab abnormalities, and they usually don't appear in these grade 3 to 4 in more than 5% of the patients. But we have to take into account that some of these rare immune-related events that can occur, pneumonitis, hypophysitis, hepatitis, can be indeed very severe and life-threatening, and there is a lot of need to pay attention to these immune-related side effects. Well tolerated, but again, cautious about the possibility of important side effects. In terms of responses, you see both drugs, and this means this is a class agent. Is this a class effect? It's not an agent effect, it's a class effect. Around 15 to 20% of patients showed objective remissions. That included, for the first time, complete remissions. And a large number of patients showed stable disease, so that only 30 to 40% have progression as the best overall response. And these tumor responses, this is experience with nivolumab that was tested earlier, so we have more mature data, occur early, usually 1 to 2 months after the treatment is initiated, and occur irrespective of the etiology, hepatitis B or C or no infection, irrespective of prior therapy, sorafenib or not, irrespective of tumor burden or location, lung, liver, other sites, irrespective of alpha-fetoproteins at baseline. And this is important. It's not only the less aggressive tumors that may be able to achieve objective remissions, and also irrespective of the expression of the ligand in tumor cells. We don't have the full picture of the biomarker analysis for these trials. We are waiting for them, but at least we know that PDL expression in tumor cells is not a good biomarker on which to make the selection of the patients. These high response rates turn to a prolonged survival. What you see here in blue is how consistent the survival of patients treated with placebo in the second-line setting is. Around 7 to 8 median overall survival, and very, very overlapping survival curves. And the survival curves for nivolumab and pembrolizumab nearly doubling the survival for placebo. And this is a reason why the FDA approved nivolumab for second-line use last year. Even more important is this slide in which you see the survival by type of response. And you see in the upper part of a graph, the survival for those patients that do achieve an objective remission, complete or partial, is very, very prolonged. And we're talking about median survival in excess of 2 years. And still, some of the patients are on responses after 3 to 4 years. Based on the results, now the industry has gone to running trials in the first-line setting in the advanced population, and this includes comparison with nivolumab of either nivolumab or with sorafenib of either nivolumab or combination of other immuno-oncology agents. The results of this trial will probably take for nivolumab probably next year, for the other trials a couple of years. But this was only the first step, because based on these early results, it was clear that there was a rationale for combining immunotherapy, low side effects, efficacy with other targeted therapies, including other immuno-oncology agents. There's a variety, more than 50 different trials now running, studying combinations. But probably the most striking thing that we've seen is this trial presented in the last ASCO meeting in June. This is a basket trial including patients with liver, gastric, pancreatic, esophageal cancer, testing the combination of atezo, which is a PD-L1 inhibitor, with bevacizumab, Avastin. You know very well this drug. And you can see here a very low number of patients, 23 patients, but a very high response rate of 65%. Totally unprecedented. And based on this very small series, FDA has granted accelerated approval for this combination in the United States. Of course, it needs to be confirmed, but you see, again, we don't have an idea yet because most of the patients had not survived for more than 1 year, whether this translates into more prolonged survival. But at least in terms of objective remissions, this is a breakthrough. So what are the surgical implications? First, we know that these drugs are able to produce responses, not only patients with a small burden of disease. You see a patient with a extensive multiple nodules involvement in the right lobe, very rapid response and achieving normalization of alpha-p2 protein and no imaging, no lesions on imaging. Not only on multiple tumors with portal vein invasion. I'm not sure you can see it from here, but here you see the extensive portal vein invasion. It's been clear soon after therapy. Same here in the starting on the right branch of the portal vein. So it's not only multiple tumors, it's also patients with vascular invasion. It's also patients with distant metastases that are able to achieve responses. So if you're able to achieve objective remissions, then the question stands, is this a treatment that we can use with a neoadjuvant intent? Should we operate on the patients that achieve objective remissions? What do we do with the patients that achieve complete remissions? Certainly there is room for starting research in the neoadjuvant setting. There is some initial intention to develop clinical trials in that field, but this is a thing we as researchers have to push in the very next future. Second thing is you can achieve objective complete responses in metastases. This is a patient, one of the patients we treated in our center. At that time, this was a clinical trial that started as an investigator-initiated and then turned to be a company-sponsored. And based on this, patient now off treatment 4 years without relapse, certainly micrometastases could be targeted by immunotherapies. So the question is this something we could use in the adjuvant setting? There is a specific clinical trial that is already running, trying to answer this question, in which a large number of patients going through RFA or resection and with a high risk of recurrence based on the presence of vascular invasion, large tumors or multiple tumors will be randomized to receive nivolumab or placebo. So the research is there. And the third point I would like to touch, and I will finish with this, is organ transplantation. Because, okay, we have active drug. Why should not we use this in the setting of liver transplantations? So there are 3 reasons. First, organ transplantations has always been an exclusion criterion. Second, checkpoints, and particularly PD-L1 is important in liver graft rejection. In animal models, the graft cells overexpress PD-L1, and this plays a role in inducing apoptosis in the infiltrating immune cells. But in humans, we know that several cell types, including the hepatocytes and the cholangiocytes, do express the ligand, PD-L1. And we know that the infiltrating immune cells express PD-1. And this is probably one of the mechanisms of tolerance to rejection in liver transplantation. And there's been, unfortunately, some reported cases of post-transplant acute rejection leading to death in young patients. And also we have some experience in a hospital in Spain. This is a courtesy of the doctor there. They treated a patient that had progressed post-rejection, post-transplantation, and you see how after nivolumab, the patient developed an acute rejection that could not be treated by severe immunosuppression. The patient ultimately died. So my take-home messages would be, we know that immunotherapy through immune checkpoint inhibition may have a large impact on HCC managers already in the second-line setting. It's being tested in the first line. It is being tested in early stages, particularly as an adjuvant therapy to surgery. Combinations seem to be even better, of course, at the price of more toxicities. But intense, durable responses may allow downstaging and warrant investigations as a neoadjuvant therapy. And finally, until we get experience from prospective study, these agents, particularly PD-1, PD-L1 blocking, should be avoided in the setting of liver transplantation. I would just like to finish by inviting you to our next meeting in London. This is going to be next week. If you're not able to make it there this year, you'll probably be able to make it next year. Our association is a multidisciplinary association in which you have the opportunity together with medical oncologists, hepatologists, radiologists, basic scientists. I'm sure you would like the environment of ILCA. Thanks a lot for your attention.